Thanks, Sean. You can start.
Okay, great. Welcome everyone to another Echo or Gecko tutorial. As most of you will probably know already, Gastro Foundation Echoes is hosted by the Gastro Foundation in association with Project Echo, initiated by the University of New Mexico. We're grateful to both organizations for making this possible and supporting engagement and interaction between colleagues in gastroenterology throughout the sort of sub-Saharan African region. These tutorials take place every Monday at 4:30. And as we go through the tutorial, if you have questions, I think probably the easiest is to pop them in the chat room, and we'll come to those questions at the end of the meeting. Okay, so I think probably I think those are the most important things for me to say. So without further ado, let's get started. I'm going to share my screen, and hopefully, if I can just check, if anyone can just unmute and inform me that are they seeing a slide saying PNETs?
Yeah, we can see it. Thanks.
You can see.
Good. Okay, great. Let's get started. All right. So I think this is an important topic. I think probably perhaps less so at the specialist level. Certainly, we expect people at the specialist level to be familiar with neuroendocrine neoplasms, but certainly at a subspecialist level, you need to be more au fait and understand a lot more of the detail that's involved. It can be a very confusing topic, but if you break it down into its constituent components, you can simplify it quite significantly. So these are uncommon or still described as being uncommon tumors, although that may well be changing, as I'll show you in a subsequent slide. Quite often they are discovered incidentally, and that can present challenges in the decision making, and we'll talk to that as well a little bit later. As I mentioned, although they are still described as uncommon, the feeling is that the incidence is increasing. There has been debate about whether this is just more awareness and the fact that more lesions are being picked up with greater use of cross-sectional imaging. But there is, in addition, an appreciation that probably there is a pathological increase in the incidence and prevalence. The majority of these tumors can be localized at the time of diagnosis, and we'll talk about sort of the modalities and the issues around that. There are a multitude of treatment options, and I'm probably going to go into less detail about this, but cover the important and varying components. But really, I think a take-home message is that certainly if there is an indication for surgery, and if the patient is resectable, both from a technical and fitness perspective, then surgery probably comprises almost always the first choice in therapy. The appropriate workup is very important in determining management, and not infrequently do we see patients who've been languishing elsewhere for months and even years without an appropriate and complete workup, which can also offer varying treatment options. So really, if one thinks about it in that respect, the management of these patients has evolved quite markedly in recent years, and some of the therapies are complex, and these patients really need to be managed in a multidisciplinary team environment. I think gone are the days where these patients can be managed in isolation between one or two people, a surgeon and an oncologist sitting on their own. Okay, so just in terms of epidemiology, I think this is quite a striking slide, or two quite striking slides. So as we said, these are supposedly uncommon tumors, but if we see how over the last few decades, from SEER data from the US, you can appreciate that the incidence of all malignant neoplasms has remained relatively stable, or at least a mild rise, whereas the incidence of neuroendocrine tumors is in stark contrast to that. So I think there's no question that there's an increased incidence. As I said, some of that may be due to increased detection. Excuse me, but also some of it is also almost certainly due to a true pathological increase. If we look at a breakdown of the different types of tumors, you certainly can appreciate that lung neuroendocrine tumors, there's been a marked increase, as there has been in small intestinal and rectal as well. But with respect to the pancreas, that's the incidence has been relatively less impressive, except in the last, say, 10 to 20 years, where there has been a sharp uptick. And we see now that, in fact, pancreatic neuroendocrine neoplasms are the fourth commonest of the neuroendocrine group. And as we've just said, there seems to be quite a sharp uptick in that. So I think this is a slide that I really want to kind of emphasize. I think if there's sort of one set of information that you remember from today, I think it's this. And this is really where a lot of the confusion for people comes in. And I think that if you can remember this sort of approach, this will enable you to deal with most tumors, and certainly to do their workup prior to presenting them in a forum to decide on management. So when we're looking, so this is a slide that I use for all neuroendocrine neoplasms throughout the GI tract. So obviously today we're talking specifically about pancreatic lesions, but it just emphasizes the point that the behavior of these tumors is very much dictated and suggested by their site. So for instance, small intestinal tumors behave differently to pancreatics that may behave differently to a gastric or rectal or what have you. So really it is very important to have an appreciation of the primary site. And as I said, today we're focusing on pancreatic neoplasms, which have certain specific features unique to them. The next step is to decide what are the clinical features or the symptomatology that this patient has presented with, or is this a case of an incidental discovery? Because again, these two groups of patients will generally be managed quite differently. Patients, if they do present symptomatically, will either present as a result of mass effects, although that is less usual, or functionality. And it's important to appreciate that when you address or interrogate functionality, you need to be looking at both clinical features and markers as well as biochemical. And when we call a tumor a functional tumor, we mean that we imply that both of these are present. So there are both clinical features and biochemical features that suggest this is a functional tumor. So for example, if you have a patient with diarrhea and a small bowel tumor with liver metastases, but the 5HI AA is normal, well, that's not a function. You can't call that a functional tumor, even though the patient is having some symptoms. You need to exclude other causes for those symptoms. So you need both clinical and biochemical positivity to call it tumor functional. Tumor markers, so chromogranin A is a sort of a general marker that we use. And obviously, if you think you're dealing with a functional lesion, you'll do biochemical markers that are relevant to that tumor. So for example, if you are talking about pancreatic neuroendocrine neoplasms, you're going to be looking at insulin and gastrin levels primarily, unless you think you are dealing with one of the rarer functional syndromes, which we'll talk about a little bit later. But obtaining biochemical markers for those is challenging in our context. Quite often the tests are only done overseas and are quite expensive. So chromogranin A is probably what we use most of the time, as I said, unless you're talking about a specific functional syndrome. What's really important, of course, is localization and staging of these tumors, and that obviously involves imaging. And there are sort of a number of modalities that are available to you here, but you need to think of them in different contexts. There's morphological imaging, which one would do with either CT or MRI. I'm going to talk a little bit about that in detail later. And then there's functional imaging, which is your nuclear medicine scans. Usually a Dotenok PET CT is where one would start. Although in the patients who have, we suspect a much more poorly differentiated tumor, you may go the route of an 18 FDG PET CT. Then we need tissue characterization. And so getting tissue in these patients is particularly important, and EUS plays obviously a very significant role here. And what you want to be knowing pathologically is what is the grade of the tumor and its differentiation. The grade we would usually decide on based on the Chi-67% receptor percentage and mitotic count. And the differentiation would be described as well, moderately or poorly differentiated, based on histological characteristics. And then lastly, staging is done via a T&M classification, which is really fairly straightforward. This probably plays less of a role, in fact, than the tissue characterization does. So when you're assessing a patient, these are the various boxes that you need to tick as you go through your workup of the patient. And this is the information that you need to have available to you when you take the patient to the MDT to decide on further management going forward. Okay. Okay, so let's focus just first of all on the functional neuroendocrine tumors. This is a more generalist slide in the sense that this refers to all of the GI neuroendocrine neoplasms. But what I really wanted to point out to you here is that pancreas features in all of them. Okay, so you need to start off with a very careful clinical assessment when you're faced with a pancreatic neuroendocrine neoplasm. And you need to consider that all of these syndromes, from serotonin secreting tumors or what used to be carcinoid tumors, remember that the term carcinoid these days really refers only to small intestinal serotonin secreting tumors that have liver metastases and the syndrome. Otherwise, so that's when we would talk about a carcinoid syndrome. Otherwise, you should be referring to these tumors as a neuroendocrine neoplasm and then referencing it by its site. So it's a small intestinal, appendiceal, rectal, what have you. So you refer to the tumor in terms of a neuroendocrine neoplasm and its site. But all the other all of the typically found or known of functional tumors can exist within the pancreas. Okay, I didn't want to spend too much time. So this slide I'll spend a little bit more time on. This is specific to pancreatic neuroendocrine neoplasms and the functional syndromes that go with that. What I want to point out to start with is that the vast majority of tumors will be, first and foremost, either if functional pancreatic neuroendocrine tumors will be either insulinomas or gastronomas. Okay. So you can appreciate that when you look at incidence over here, okay, so insulinomas are the commonest, followed by gastronomas, and then you'll see that all of the others are actually pretty rare. Okay. The things like Lipomas, WDHA syndrome, Lipomas, even those, we're talking about probably 100, more or less in the region of 100 to a few more cases in the literature. Okay, so these are really not all that common. And even if you're a dedicated pancreatic surgeon, you're probably going to see a handful of these in your life, in your career. Okay, but as I said, first and foremost, so insulinomas, those are the commonest. The vast majority are located in the pancreas. Less than 10% are malignant. And remember that proportion of these will be associated with MEN1 syndrome. The typical symptoms are those of hypoglycemia, and you'll probably be familiar with Whipple's triad. And really that is hypoglycemic symptoms. Remember, hypoglycemic symptoms can be divided into the catecholamine secretion component. So obviously when you go hypoglycemic, your body increases its adrenaline production and catecholamine excess, and you have symptoms like palpitations, sweating, maybe nausea. Together with that, there are the neuroglycopenic symptoms. So that's going to be things like confusion, depressed level of consciousness, maybe seizures, and so on. Okay. And as we said, the Whipple's triad is the classical constellation, and that is hypoglycemic symptoms in the setting of hypoglycemia and resolved following oral intake of sugar-containing substances, fluid or food. Okay, Gastroent tumors, probably slightly less common than insulinomas. Remember, there's the gastrinoma triangle, which includes the duodenum, the pancreas, and the distal biliary system and the tissues around that. So gastrinomas can occur in that region. Far more of these are malignant, 60 to 90%, and a greater proportion associated with the MEN syndrome. So typically, people remember that these patients obviously present with recalcitrant ulcers or ulcers that occur in unusual sites. Often the patients will have pain as a consequence, but remember the other symptoms as well, and that includes diarrhea, as well as esophageal symptoms or significant reflux symptoms that are difficult to control. Okay, all right, and then there's the less common things. So things like Lipomas, which is vasoactive inhibitory peptide, which also results in a syndrome called the WDHA syndrome, watery diarrhea, hyperkalemia, and alkalosis. So the majority of tumors occur in the pancreas, although they can occur in some other sites. Again, a majority are malignant, and we've mentioned the typical syndrome: diarrhea, hyperkalemia, dehydration, and alkalosis. Glucagonomas, obviously these patients present with excesses of sugar, excesses of sugar. They are obviously glucose intolerant or frankly diabetic by the time they see you. An important component is to remember is they often get a rash called a migratory necrolytic rash, and that can be a clue. I know of one patient who very well diagnosed by a GP with this diagnosis. These patients often have a degree of weight loss as well, but it really takes a very astute clinician to consider and make this diagnosis. Somatosatinomas, these patients present with gallstones, diabetes, and as well as diarrhea. Okay, and that's really where I'm going to stop. I think those are the important conditions or syndromes that you need to know about, but bear in mind that there are a number of others, in particular things like growth hormone releasing factor, as well as insulin-like growth factor, CCK, and a couple of others. But really, I don't think anyone in an exam is going to expect you to know this in detail. You should just know that there are other syndromes that may occur. All right, so this is what we've just been through. So I think we can move through that. I just wanted to, the next couple of slides kind of just rehash what I've just said. So just as we just mentioned, Whipple's triad, symptoms of hypoglycemia, documented hypoglycemia, resolution of the symptoms when you provide therapy to increase the glucose levels. And you can divide your symptoms into neuroglycopenic symptoms and those associated with catecholamine release. As we mentioned, sweating, anxiety, palpitations, and Neurological being seizures, difficulty waking, confusion, lethargy, even weakness, and visual disturbances. Okay, we've mentioned the triad that's required to make the diagnosis. Symptoms during fasting, low serum glucose, relief following glucose admin. So that's the Whipple's triad. Now, to make this diagnosis, you can do random glucose, insulin, and C-peptide testing. But really, the gold standard in terms of making a diagnosis is a 72-hour test fast. This is done in hospital with insulin and glucose levels done every 6 hours. And the test is stopped either, whichever one reaches first, either if the patient develops neuroglycopenic symptoms or if one reaches 72 hours. If the patient does develop symptoms, then the bloods to do are glucose, insulin, C-peptide, and proinsulin. Okay, gastrinomas. So the syndrome typically described as Zollinger-Ellison syndrome. As you mentioned, abdominal pain usually related to ulceration, but don't forget reflux disease and watery diarrhea are also important components of the syndrome. The peptic ulcers may be recalcitrant, but also in unusual places. And remember that this is commonly part of MEN 1. An important point is that when you do gastrin, and this applies to chromogranin A as well, that PPI levels can falsely raise the chromogranin and the gastrin. So ideally, the test should be done with the patient off a PPI. However, if you have significant concern that the patient may become overtly symptomatic or develop complications while off the PPI, you can put them on an H2 antagonist in the interim. Certainly, it is said that if you have massively raised levels, like more than 3,000 or 4,000, that's really pathognomonic. But it is suggested that if the levels are equivocal, less than 2,000, then the patient should probably go on to have a gastrin stimulation test where patients are given secretin and then a serum gastrin. And as you'll see, one can also test gastric pH. We'll come to that in a second. Okay, Lipomas. Okay, I think we already mentioned those symptoms. I'm not going to spend more time there. Sorry, my mouse is glucagonomas. As I said, we mentioned this already as well. So diabetes and weight loss. We didn't mention the stomatitis, but that can be a component as well. And then there's this rash, which is sort of a reddish raised rash, which is called necrolytic migratory erythema. And it will be picked up in different places on the body at different times. Somatostatinomas, diabetes, steatorrhea, and hyperchlorhydria are the main features. Okay, so when we're faced with a patient with a suspected or confirmed neuroendocrine lesion, your starting point is a careful clinical assessment, and we've been through up above all of the sort of syndromes and symptoms that you should be asking about when a patient presents. So careful clinical assessment is your starting point. The biochemical assessment, we've just said chromogranin A is probably the standard of care at the moment. But remember, these are a class of secreted proteins produced by neuroendocrine cells in a variety of organs. And so elevated levels can occur in a number of different settings. So one should be cautious about the interpretation of chromogranin A. And there's a lot of criticism that has come about of chromogranin A when it's used as a screening tool. So one should just be cautious about that. Probably its best role is in once a patient has a confirmed tumor histologically, and the chromogranin A is then meant to act as a baseline for following the patient subsequently and detecting recurrence if the chromogranin A was raised initially. So elevated levels can suggest the presence of a neuroendocrine neoplasm, but not necessarily at site. And it is positive in both functional and non-functional tumors. As I've just mentioned, it's most useful in monitoring treatment response and surveillance, and possibly in prognosticating when it is markedly raised. Bear in mind that it's, as we just said, it's not elevated in all neuroendocrine neoplasms. It may be elevated in the absence of a neuroendocrine neoplasm, and certainly that's often the case when falsely elevated levels are detected in patients who are on a PPI. Okay, moving on to imaging of these patients. So, as I kind of indicated earlier, I divide imaging into morphological and functional, and you need to do both. Both are important in planning management, considering your various treatment options, and in providing a baseline for following these patients up subsequently. So the morphological imaging can be done by three modalities. CT scan, this is obviously the first investigation, almost always, that is done. And the kind of clues that you're dealing with a neuroendocrine neoplasm is that these tumors are often hyper-enhancing, especially in the arterial phase. And so if you're suspecting a neuroendocrine neoplasm, it's often best to go and look at the arterial phase first before looking at the venous phase. And you can appreciate here that this lesion, although it's still visible there on the venous phase, it's more marked and prominent on the arterial phase. So it's hyper-enhancing in the arterial phase, and often less so in the later phases. And because of this characteristic, one can often miss small liver lesions, especially when looking in the venous phase, but also for that matter in the arterial phase. So liver lesions can be particularly difficult to pick up on CT. Endoscopic ultrasound is probably your best modality for examining the pancreas, getting good views of the pancreas, and I'll show you in a moment what EUS imaging of a neuroendocrine neoplasm generally looks like. Bearing in mind that I think CT has limitations for visualizing neuroendocrine neoplasms in the liver, CT is probably the best for examining the primary, but MRI, I think, is probably far and away the preferred modality when we are trying to detect liver lesions. So here's an example of endoscopic ultrasound. You can see how, so this is a very typical neuroendocrine neoplasm. They're often very well circumscribed, very well defined. The tumor itself is often very homogeneous. But you can see here, I mean, this is a 1 centimeter lesion, basically, and you can see how well this is appreciated on endoscopic ultrasound, and getting tissue from this for grading would be also relatively straightforward. You can get other information as well, such as proximity to vasculature and proximity in particular to the pancreatic duct, especially if you are considering doing an enucleation of, say, a gastrinoma or another type of functional lesion. Moving on to the liver imaging. So I'm going to show you here. Here you can see, so this in fact is the same patient. The cut's done at the same level, and you can appreciate that it's very difficult to say, and I think most people would probably miss the fact that there's a lesion there on first inspection of the CT scan. But here you can appreciate very clearly the lesion demonstrated over there on the MRI and there peripherally. And I challenge anyone to say that they can see those two peripheral lesions on the liver on the CT scan. Okay, so that's morphological imaging. So as I say, certainly my view is that if you, most patients should probably have an endoscopic ultrasound, especially if there's been difficulty identifying the lesion, the primary that is. And sometimes CT and MRI struggle to do that. So for example, when we're hunting for an insulinoma, endoscopic ultrasound really is invaluable because these lesions can often be difficult to localize. And then when it comes to the liver, really an MRI is what you should be getting. Okay, when we turn to the functional imaging, so this is usually a 68 gallium dotatate or Dotanok PET CT. And what happens here is that radio-labeled traces are given that bind the somatostatin receptors, and that's how the lesions are localized. It aids identification of both the primaries and metastatic disease, But quite often we know where the primary is, and the main role here is to identify metastatic disease, and in particular, identify whether there is extrahepatic metastatic disease, because that generally then would change the management options and the prognosis. Certainly, the primary treatment for liver metastases in pancreatic neuroendocrine neoplasms would still be resection if it is technically feasible and appropriate. But once you've got extrahepatic metastatic disease, that changes somewhat. Use of intravenous contrast together with the PETs can improve the sensitivity. And as we said earlier, the dotatate and dotanox scans are much better for the well and moderately differentiated tumors. But once you get into the poorly differentiated tumors, in fact, 18-FDG tends to perform better. And so where we have a concern about poorly differentiated tumors, we may choose to do an FDG PET in addition. Okay, important aspects around the tissue characterization and histology. So obviously histology is important to establish the diagnosis, but also to grade the tumor. The way we typically do it, as far as pancreas is concerned, obviously would be endoscopic ultrasound. And so what's important about the endoscopic ultrasound is that how the pathologists grade the tumor is looking at the mitotic count and looking at the Ki-67. Now the Ki-67 they do with immunohistochemistry, and that is done on the cell block rather than the cytology slides that you might prepare when you first when you do your initial biopsies. So it's important that you give sufficient tissue, put sufficient tissue into the cell block, that an adequate cell block can be made, so that the pathologists have sufficient tissue and sufficient cells to count. There has to be a certain number of cells available, because obviously a Ki-67 is a proportion. It's a percentage of all the cells that express the Ki-67 receptor. So if you haven't got sufficient cells, they can't actually work out a percentage. I forget the exact number. I think it may be in the region of 500 cells, but I'm open to correction. We can find that out and let you know that at a later stage if necessary. But the point being is you need an adequate cell block specimen in order to accurately grade the tumor in terms of Ki-67. So when we talk about classification and grading criteria for neuroendocrine neoplasms, it's important to be aware of the WHO classification. And this was revised in 2019. And so just to emphasize the terminology that we're talking about. So first of all, you'll notice that I've been talking about neuroendocrine neoplasms. Okay, so that's the term that is all-encompassing for all of these neoplasms or lesions. Okay, the tumors that are of a lower grade, and so by that we mean grade 1 and grade 2, as well as the grade 3s that have a lower mitotic rate and lower Ki-67 index, those are termed neuroendocrine tumors. Okay, the ones that are poorly differentiated, and these tend to have higher mitotic rates and higher Ki-67 indexes, those are termed neuroendocrine carcinomas. All right, so I think you just need to understand the semantics of it. You need to be careful about the terms that you're using to describe these neoplasms. Okay. So neuroendocrine neoplasms encompass both tumors and carcinomas. The tumors can be grade 1, 2, or 3, but they are all well differentiated. The poorly differentiated tumors are termed neuroendocrine carcinomas, and you get small cell and large cell types. The tumors will tend to have lower mitotic rates and lower Ki-67s. Grade 1s are less than mitotic rate less than 2 and Ki-67 less than 3. The intermediate, the grade 2s, are mitotic rates of 2 to 20, Ki-67 of 3 to 20, and then the grade 3 neuroendocrine tumors tend to have mitotic rate greater than 20 and a Ki-67 greater than 20. But these will usually be, say, in the 30s and 40% range. When you get into the 60, 70% range, that's usually where we are talking about neuroendocrine carcinomas, either small or large cell types. Okay, and then lastly, just remember that there's uncommon sort of mixed neuroendocrine neoplasms, which can be both well or poorly differentiated tumors and variable other characteristics. Okay, we're going to move on to treatment now. And so suffice to say, as I said in the beginning, the ideal treatment is surgical. Surgical represents the cornerstone of curative therapy. Because the ideal treatment is resection of all macroscopic disease. And that can include metastatic disease provided it's localized to the liver. The approach, of course, is greatly influenced by functionality. So I think you need to, a first important step is to divide your tumors. Are you talking about a functional tumor or are you talking about a non-functional tumor? If you're talking about a functional tumor, then your treatment is going to be aimed both at managing symptoms as well as the oncological aspects. If you're dealing with a non-functional tumor, then obviously you're only talking about oncological concerns. All right, non-functional neuroendocrine neoplasms are obviously being diagnosed a lot more these days in the era of modern imaging. Generally speaking, they have a more benign behavior. Certainly, the smaller ones are deemed to be less aggressive. Although having said that, up to about 15% of neuroendocrine neoplasms that are under 2 centimeters may have microinvasion or nodal metastases, but usually without liver metastases. There's probably about a 10%, 0 to 10% rate of liver metastases in tumors under 2 centimeters. There is some controversy around the management of non-functional lesions less than 2 centimeters, and we'll talk about that in a moment. And the management of these patients really is an individualized one. The management of metastatic disease, we're not going to, is very along similar lines, say, as colorectal metastases, in that what's important is, can you leave sufficient functional liver reserve behind? But patients, it is another important aspect to take into consideration is that patients can live for prolonged periods of time, even in the setting of unresected metastatic malignant disease. And so current guidelines, until recently, guidelines suggested that you could undergo liver resection so long for oncological reasons. So in other words, you have a non-functional pancreatic neuroendocrine neoplasm with liver metastases, and you can resect the primary and the metastases provided you remove 90% of the bulk of the tumor. In other words, it was acceptable to pursue a surgical approach even if you left 10% of the malignant disease behind, because these patients would still have probably close to 70 to 80% 10-year survival rates that were quoted. The percentage that you can resect has now decreased in keeping with those philosophies. And so the current guidelines would say that you can perform resection of the primary and liver metastases, provided you remove 70% of the bulk of the disease. However, it should be kept in mind, so as I've said, surgery still remains the cornerstone, and in young fit patients, it would generally be the way that one would go. But one should keep in mind that there are also numerous adjunctive therapies that have become available in recent years, and we're going to talk a little bit about that in a moment as well. So just to talk about treatment of some of the individual tumors. So suspicion of an insulinoma, clinical suspicion based on Whipple's triad. Patient undergoes a 72-hour fast. The course would then be, if the test then came back positive, you would then get cross-sectional imaging, which in this case would probably be happy with a CT, but if it's not clear, you might add an MRI. And if the lesion is visible and you've made the diagnosis, if you have a single lesion, you would go and remove that, preferably with an enucleation. If there are multiple lesions, then you may need to decide which is the dominant lesion, and that can be established by performing arterial sampling, a venous sampling with arterial stimulation using calcium. I think in this setting of multiple lesions, I think endoscopic ultrasound is worthwhile to consider in this setting. And by way of example, I can tell you that I saw an MEN patient a few months ago. The patient presented with features of hypoglycemia. Insulinoma was identified in the tail of the pancreas, but nothing else was seen. Because of the history of MEN, we wanted to be sure we excluded any multiple lesions. And in fact, this patient had a second lesion detected in the body of pancreas that was missed on CT and MRI. So really, if you should have a low threshold for using EUS to either identify the primary lesion or if there's a chance of there being multiple lesions. If you can't identify the lesion, as this algorithm suggests, you go on to EUS, then you go down the route of finding lesions. If you don't find a lesion, then a consideration again should be given to arterial stimulation venous sampling. If identify a lesion, again, go down the resection route. If no lesion, then you really got to consider whether this is a true insulinoma, being an identified neoplasm, or whether this isn't something like neoplasms, although that term is used less often these days. One really talks about sort of islet cell hyperplasia. Okay, moving on. So with gastrinomas, we've mentioned your starting point would be measuring the gastrin level. If you have a gastrinoma, typically, obviously, most of the time, your gastrin level will be markedly elevated, and you will then consider that this is indeed Histology syndrome. Now, this is a guideline from a European Neuroendocrine Tumor Society, and obviously, this is the textbook process to follow, and they would suggest that you go and do a gastric pH measurement. If you are dealing with a pH that is less than 2 and your serum gastrin was greater than 10, then almost certainly you're dealing with a Zollinger-Ellison syndrome. If the gastrin was not that high, then you would consider doing a secretin stimulation test. Now, alternatively, if the pH is greater than 2, make sure that you're not on a PPI or other acid suppressing drug. And if so, consider how you can proceed to repeat the testing off a PPI. I think, in practice, I suspect this is not done all that often. It may be done in major sort of research centers, but I think if you have a highly suspicious biochemical marker, then probably it would not be unreasonable in our setting to proceed straight to tumor localization using cross-sectional imaging and perhaps endoscopic ultrasound, and then manage accordingly. Okay, if we turn our attention to the non-functional tumors, so again, you need to take into consideration clinical presentation. Obviously, these patients usually will be asymptomatic, and the lesion is picked up on imaging, usually cross-sectional imaging, as an incidental finding. Now, we mentioned the issues around size. I think so. The first thing to remember: so if you have a resectable lesion, no distant metastases. Although we've mentioned that is not necessary, does not necessarily exclude you from surgery, but certainly if you have an isolated lesion greater than 2 centimeters, that should be resected. Okay. and you're either going to decide, and you're going to decide on how you're going to do that based on the anatomical location in the pancreas. However, it is a bit of a gray area for tumors that are less than 2 centimeters. Certainly, most guidelines these days would say that if you have a lesion, an incidental lesion of less than 1 centimeter, you would manage that conservatively. Less than 1 centimeter has almost no association with malignant or metastatic disease. So that would then, it would be reasonable to observe that. The gray area exists in the 1 to 2 centimeter category. And in the 1 to 2 centimeter category, if you looked at all comers in that group, about up to 10% of patients are subsequently found to have distant metastases, and about 20% of patients may be found to have nodal metastases. And so these are ENET's guidelines. They're 6 years old now, but they advise their recommendations are based on histological findings. So in other words, you've got a 1 to 2 centimeter lesion in the pancreas, you go and biopsy it. If it is a grade 1 or low grade 2, so that's based on your mitotic count and your Ki-67. And remember, as I said, that's why it's important to make sure you've got enough tissue in your cell block that you can make that determination accurately. So surveillance for grade 1 or low grade 2s that are asymptomatic, especially if they're in the head, which is a more sort of a higher risk resection, and there are no radiological signs suspicious for malignancy. On the other hand, if the lesion is a higher grade 2, or if the patient has symptoms, although obviously that's then not an incidental finding, and patient wishes, then you may consider surgery. Now, if you are under surveillance, you should be starting with EUS and probably either EUS or MRI every 6 to 12 months. I don't say for what period you would do that. I generally do it 6 monthly for 2 to 3 years and then extend to yearly after that. If there's no change, then the surveillance obviously can be increased. When you should become concerned is if there's an increase in size more than 5 millimeters or the overall the lesion grows greater than 2 centimeters. So the surgery, so tumors less than 2 centimeters, not involving the main pancreatic duct. If you've decided to resect this, it can be enucleated. Resecting nodes should be done, but that's more for prognosticating and determining your TNM stage and determining specific survival. As I mentioned earlier, nodal positivity is associated with size. Tumors greater than 2 centimeters have about a 50% positive nodal rate. Tumors less than 2 centimeters have up to, it's actually about a 20% positive nodal rate. PNETs that are greater than 2 centimeters, that's these patients should have a more formal pancreatectomy because of the concern around, a greater concern around malignant spread. And really, what you're going to be considering most of the time is either a Whipple as opposed to a left pancreatectomy. Central pancreatectomy obviously is described, but this is an operation that has a higher risk and probably a lower nodal yield. And that's not really an operation that we've pursued in our practice to any great degree. Surveillance post-resection, the risk of recurrence is variable and related to nodal status, functionality, size, and grade. And we can divide patients into low, intermediate, and high risk. And based on that, we can follow them up either at 12, 6, or 3 monthly follow-ups. Okay. This is obviously a talk aimed mostly at a surgical audience. I am aware that there are non-surgeons in the audience, but also, you know, as a member of an MDT, the surgeon needs to be aware of what the other therapies are that are available. So there are a multitude, and so what we're talking about is this is essentially second-line therapy. Okay, so as we said earlier, If the patient has resectable disease, surgery is always the preferred treatment. All right. If surgery is not possible, or if surgery is, say, incomplete, in other words, there is disease left behind, then we need to look at second-line therapy. Almost always, the first second-line therapy is a somatostatin analog. And although it's a bit of a gray area at the moment, most people would say a patient should go onto a somatostatin analog and then be surveilled or observed. And if there is progression of disease, then alternative therapy considered. Now, and then there's this range of alternative therapies that you see here in front of you. Now, certainly what has come into vogue as a very popular therapy in the last few years is that of PRRT, which you see at the bottom of the page there. That's peptide receptor radiotherapy. And what that is usually the patients receive a labeled lutetium. And it's the same principle as the PET CT scan, whereby the ligand, the somatostatin, binds the receptors, and that ligand is labeled with a radioactive substance that then shows up on the scan. Now, all that you do here is that, again, you have a ligand that binds the receptor, except that now you add on a therapeutic radioactive substance. And so that then treats the somatostatin, the neoplastic cells that have somatostatin receptors preferentially. This can be a highly effective therapy. As I say, certainly becoming an established second-line choice to somatostatin analogs. And it even is being utilized in some neoadjuvant settings as well. So I haven't really delved into that concept, or maybe talk about it a little bit more in a moment. The other, so PRRT is a good systemic therapy and a good liver-specific therapy if you have isolated liver metastases as well. And that would often be our sort of next choice after somatostatin analogs, bearing in mind that in the state sector, we don't have access to somatostatin analogs in any case. So in fact, PRRT has become our second-line option secondary to surgery. However, there is a limit to how much PRRT you can give. And what we are in the process of developing in our practice is that of TACE. So transarterial chemoembolization, obviously a well-established therapy for HCCs, but it certainly is also a well-described therapy in the literature for neuroendocrine metastases. As I say, we haven't, in Cape Town, we haven't utilized it much, but it's something that we are looking at. Selective internal radiotherapy, so that is SIRT, and that's where you utilize sort of radioactive beads to mass lesions. Again, that's not something that we've had available in the state sector. It is available in the private sector, but I think it's becoming less used these days as a consequence of the degree to which PRRT has been taken on. Together with TACE, one can also do bland embolization of metastases, especially liver metastases. So that's above there. That's called just TARE. And then, of course, don't forget ablative therapies. So microwave ablation can also be used for smaller lesions that are difficult to resect for whatever reason. If we look at the more medical therapies, chemotherapy is available for pancreatic neuroendocrine neoplasms, especially, and it's more effective for the higher grade tumors. So, the neuroendocrine carcinomas, it's less effective for the more well differentiated tumors. And I want to just mention there. So we have had 1 or 2 patients where we have considered a neoadjuvant type approach, and we have used chemotherapy in combination with PRRT, and we have seen some quite impressive responses to that, with the view to then going on to hopefully resection of both the primary and metastatic disease. So I think that's chemo as a conjunct to PRRT in the neoadjuvant setting may be something that is evolving, and that's maybe something that you need to be aware of. The other sort of medical modalities that are listed here, so again, these are usually therapies that are considered once there is progression on a somatostatin analog. These therapies are, everolimus is probably the more commonly used one, but there's also sunitinib and interferon alpha has been used in the past. But these medications come with very significant side effects and risks, and are generally very poorly tolerated, with sort of perhaps some effect, but certainly weighing up the risk versus the benefit, the benefit is less. So I think in current practice, people are certainly leaning more towards the PRRT and other liver-directed therapies primarily. Okay, but I think, you know, when you consider all of this, just once again, you know, these patients really are best managed in a well-constructed MDT. That means you need oncologists who are experienced with all of the therapies. You need endocrinologists to aid with diagnostic workup and considering the various sort of options in terms of localization. You need radiologists, you need surgeons, obviously, and indispensable are the nuclear physicians. So with so many kind of therapies and options available, and it really can be difficult to decide sometimes which is the best therapy for a patient. It really is important to have these patients managed in MDTs. Okay, that brings us to 28 minutes past 5. I hope I haven't overstepped my time too much. I will have a look now and just see what questions we have. Otherwise, people are welcome to, there's a, at the bottom of the screen, you'll see there's a section that says reactions. And within that, there's an option to raise a hand, and we can come to your questions. So Gert has asked, H2 antagonists aren't available any longer. Any suggestions, or do we go straight to the secretin secretion test? So Gert, forgive me, where are you practicing?
Hi, Sean. Gert van der Merwe. I'm at Universitas Academic Hospital. I was in private practice for quite a while, but the H2 receptor antagonists I know is, well, if you can get them, very difficult to get them.
Okay, I have to be honest, I wasn't aware of that problem. My understanding was it was still available here at Groote. I'll need to find out about that. But yeah, look, it's a difficult scenario then. I mean, I think it's reasonable to do the test while the patient's on a PPI. You know, if you get a value, you get a gastrin level that's more than 5,000, then that's probably still relevant, and you're probably still then going to go on to image the patient. Secretin secretion tests are not easy to organize either. Secretin is actually quite difficult to get hold of locally as well. So one kind of is a bit stuck there. As I say, I think the thing to do then would probably be to try and exhaust your localization tests before considering other options.
Thanks. These two other questions which
Yeah.
which are cancelled. Thanks.
Okay, no problem. Yalda, I see your hand up.
Hi, Sean. Thanks for the presentation. I actually have two questions. One is regarding the gastrinoma. When it comes to the resection of the gastrinoma, especially if it's in the duodenum, they're talking about enucleation versus local resection and lymphadenectomy versus doing a Whipple. So just wanted to know when you can go for either of them.
Yeah, so look, again, it does depend on the context. If it's an MEN, if you think it's a malignant, if you've got malignancy there. But, you know, as we noted, a significant proportion of these patients will present with malignant disease. The majority of practitioners, though, would say is that if it is enucleatable, it's going to be individualized. It depends on where the lesion is localized. But if you have a gastrinoma sitting in the sort of in the duodenal groove or separately, and you can resect it without a major Whipple's resection, then most people would say you should consider that.
Okay. Cool. And my second question was about the mixed tumors. I know when it comes to the other tumors, the PNET or non-PNET neuroendocrine neoplasms, the treatment option is different if they are well differentiated or poorly differentiated. But the mixed tumors, even though we have a well differentiated type, they don't differentiate in the treatment. Is there any specific reason for that?
Sorry, Yelda, I'm not sure I quite understood you.
So the mixed neuroendocrine tumors, when it comes to the management, they put them under the same category as the grade 3 carcinomas.
Mm-hmm.
But we know the mixed tumors, they can be well differentiated.
When you say they, who are you referring to?
NCCN.
Okay. So often those lesions will be higher grade, but what you're going to need to do in that setting is assess it. You know, you're going to get your Ki-67 count and your mitotic count. You're going to probably do an FDG PET and a Dotonok. And if you're dealing with a lower grade tumor, or rather a better differentiated lower grade tumor, then you're going to lean more towards those therapies. Again, if it's resectable, you're going to resect it. If it's not resectable, then you're probably going to be thinking about somatostatin analogs and PRRT for the better differentiated tumors. And for the poorer differentiated ones, you're going to be leaning towards chemotherapy. Okay. So you're going to base it on the biology of that individual tumor. But the reason why they've left it broad there is because, you know, the tumor could be anywhere in that spectrum.
Mm-hmm. Okay, thanks, Sean.
Okay. Nkoli.
Afternoon, and thank you for the great talk. I don't know if you can hear me.
I can hear you nicely, thanks.
Okay, thanks. I just wanted clarity on you mentioned that there's a subset of patients who have whom you can give chemo with a combination of PRT as on a neoadjuvant setting. And I just wanted to ask, are those patients who have the neuroendocrine carcinomas, or you can also give patients with NET grade 3, but with higher Ki-67s? I don't know if maybe you mentioned it, but I just missed it.
Yeah, so Nkoli, let me just first off start by saying, just bear in mind, this is very, shall we say, novel therapy and a novel approach. You won't find a lot of literature on this. You certainly won't find a lot of sort of big numbers supporting this approach as yet. And you won't find this in any of the guidelines. So, you know, I think if you're in an exam type situation and so on, I think, you know, what you want to say is that you are aware that there are neoadjuvant approaches being developed. And in some of those, people may be using chemotherapy in combination with PRRT, but it's certainly not a textbook answer or approach as yet. So, you know, most practices, I mean, even you know, in our MDT in Cape Town, I think that we've got like a handful of patients that we've tried this with. But the point, you know, and when I think of a specific patient that we did this with, what was important about this patient is that we were concerned that he might have tumor and metastases of differing Ki-67 count and grade. So this was a patient where we wanted to cover sort of both ends of the spectrum, if you will. So just remember that like different parts of the same tumor can de-differentiate or have different differentiation, and metastases can de-differentiate. And in fact, that's exactly what had happened with this man. He had his primary pancreatic tumor had a Chi-67 of 10%, but some of his liver metastases had Chi-67 counts of 70 to 80%. And so in that setting, we obviously wanted to treat both. So it made sense to give chemo and PRRT. I think it is important to have in mind why you are employing a neoadjuvant approach. This is not necessarily, we're not at the point where we're thinking about it the same way as what we're thinking about ductal adenocarcinoma, for example. Reasons for performing neoadjuvant therapy here is a lot of the time, if we're trying for conversion therapy, often the pancreatic tumors can be quite large, involving significant vasculature, and represent quite a difficult and potentially hazardous surgical resection. And the PRRT may shrink that tumor down and make the surgery technically much easier. The other reason for doing it would be maybe that in the current state of affairs, the extent of disease involving the liver, for example, precludes a resection. And so at that stage, you're considering the patient irresectable because of the degree of metastatic disease, but PRRT may change that, and you may convert that patient to resectability based on the response of the metastatic disease. So I think that's what I would say you should have as sort of the indications in your mind as to when to consider neoadjuvant therapy. But as I say, as a concept, it's still very new, I think it's something perhaps you can mention in an exam, but be quick to add that this is not it's not yet recognized as standard of care. People are not yet, we don't yet know exactly how to do it, and certainly we still need to see the evidence that it actually results in improved long-term outcomes.
Okay, thank you. Thanks.
Yeah, I see VG Naidu is in the call, and he's just raised a point, and thank you for that, VG. Just that there are many alternative causes of an elevated fasting gastrin other than PPI. VG, would you want to make a comment?
Hi, Sean, can you hear me?
Yes, we can.
Am I audible? Oh, okay,
yes,
good.
You are.
Yeah, no, there's a fairly long, list, actually isn't so long, list of elevated, gastrin helico. So you have to exclude atrophic chronic, gastritis, especially of the, corpus, helicobacter, and renal failure as well. They can give you a false elevated, gastrin. So I think if you suspect it, and it is one of those things I try to refrain from actually asking people to order unless you have a high index of clinical suspicion, because often somebody goes off and orders all these hormones and chromogranins, and then you have these elevated your results that isn't in keeping with the presentation of symptoms, with the clinical presentation of the symptoms. Endoscopically, for a Zollinger-Ellison syndrome, it's quite when you scope these patients, be careful of ulcers in unusual areas, ulcers in the corpus, in the second part of the duodenum. And the other clue is the antrum is actually spared. And in the upper part of the stomach, you'll see these folds that are very succulent, and there's usually plenty of fluid in the stomach as well. And that's from the trophic effect of the hormone itself. So you've got plenty of fluid in the stomach, you've got these succulent folds, a spared antrum, ulcers in unusual places, lots of esophageal erosions. And endoscopically, you can actually have a very high index of suspicion. And so you add scope now. The key thing to do there is to aspirate some of that fluid and check if the pH is under 4. If it's over 4, or if it's alkaline or like neutral, it isn't a Schollinger-Ellison syndrome. Then you've got some other etiology that's giving you this this high level of sort of gastrin. So always check the fluid pH at scope, and it's something I think people forget to do, and it's fairly easy. You just have to actually stick in a syringe on your scope and just suck. And you can either do a litmus in the room, or you can send it off to your sort of lab for a pH. But I think I just want to emphasize that something we do ask our it's actually something we ask our fellows, even in an exam, other causes of hypergastronemia.
Great. Yeah, no, absolutely, Vijay. Thank you very much for those comments. Very valuable. I'm afraid we actually are over time, and so I think we need to bring the meeting to a close. I apologize if there's still any remaining questions. But yeah, I think just to finish up, thank you to Karen Fenton for helping to organize. Thanks again to the ECHO team from India and from the University of New Mexico in making these sessions possible. Again, thanks to all of you for attending and your comments and questions, and Vijay for your valuable comments at the end. Please note that there's a feedback form available in the chat room, and we'd appreciate your responses to that. The recordings of this will be available on the Gastro Foundation website. And again, thanks to the Gastro Foundation for their support in holding these meetings. Next week's meeting is on familial adenomatous polyposis, and that will be with Dr. Zahir Mula. Good. Okay. Thank you, everyone. Karen, I'm not sure if you want to make any final comments.
That's all. Thanks, Sean. That was great. There has been a message from the Indian team that they weren't able to put the feedback up, but people are welcome to message me or to email me with any comments. We welcome that. So thanks. That was great.
Okay, super. Thank you, everyone.
Thank you. Bye.